4 years with a great team of Mark, and I guess I got to apologize for Jeff for stealing all those patients all those years at the University of Chicago. Sorry, Jeff. Does a pretty good job getting back. But I particularly want to thank my patients and all the patients in the audience. You are our inspiration. You're the reason we come to work every day. Thank you for spending the time this evening to come. I really appreciate it. I was given this title, Novel Orthopedic Oncology, by Mark. He's an internist, and those of you who don't know, there's some interprofessional issues around orthopedic surgeons and internists. And the joke is, where do you hide something from an orthopedic surgeon? In a textbook. So he gives me a title with Novel Orthopedic Oncology. But the best 5 years of my life were kindergarten. They were quite good. And I'm going to talk to you mostly about function of upper and lower extremities around the idea of sarcoma resection, and when we have to do an amputation, and what we're doing now in regard to patients that eventually need amputation. So this has been a little bit of a repeat for you, but you have to understand that sarcomas start sort of with a few cells, and they grow out round, and they grow round until something makes them change their shape a little bit. And that barrier can be a bone or skin or something we call fascia, which tends to flatten them out, and then they sort of change shapes. But they're not like carcinomas that grow in and around things and really snake in around vessels. They tend to push things out of the way as opposed to growing around them. There's this thing that Jeff mentioned called pseudo-encapsulation. They don't really have capsules around them. They'll feel like they're capsules. And sometimes when surgeons take them out, they say, well, it was well encapsulated. The facts are most of the time they're not encapsulated. And from an orthopedic perspective, it's important to us that most of them start and stay in an anatomic compartment. Now, you don't think about compartments, but I do a lot. So in the arm, there's a compartment in the front of your arm that allows you to flex your elbow up, and everything in the back of the arm allows you to extend or to push away. Because they stay in one compartment, we can oftentimes take them out and rearrange things so you keep that same function. And we work very closely. The only group not here tonight are plastic surgeons that are helping us in rearranging some of those muscles and making things work just a bit better. So this is a histology slide, and I apologize. It's like I understood there'd be no math on this exam, but this is a slide from high school. This is a myxoid liposarcoma here. And this is how it pushes against this thing called a pseudocapsule. And if you're operating, you're not seeing the microscopic side. You're just putting your finger in and dissecting it. What you'll end up doing is dissecting along this zone here. And if you do that, you can see you leave small satellites of sarcoma behind. Okay, that's a problem because then that tumor is going to grow back. And now we count on radiation therapy and chemotherapy to kill some of these satellites. But this is an important consideration when it comes to sarcoma, unlike some other tumors we tend to deal with. This is another example. This is what muscle looks like when it's sectioned histologically. And you can see how these sarcoma cells actually run right up and down the fascicles of those sarcomas. So that puts you at higher risk of recurring if you just shell them out or have problems like that. Now, it also tells you that local recurrence is not necessarily the fault of the tumor or the patient or the doctor, that every tumor is a little bit different. Not all of them do this, and some patients, just from the biology of the tumor, are at higher risk of getting a local recurrence. The treatment, though, again, is wide resection. We try to get outside everything. We don't want to see the tumor. We want to be in normal tissue all the way around. Now, sometimes that's not possible because I don't want to take the femoral artery. I don't want to take the sciatic nerve. I don't want to take important things around it. So sometimes we get closer, and that's when Dr. Hayes helps us out with the radiation therapy. Chemotherapy helps for systemic disease. It probably helps a little bit locally as well, particularly with certain tumors. And then a big part of my life is working rehabilitation and trying to get the best function possible. This is my academic grandfather, a man named Dr. Enneking, who played basketball at Wisconsin and then was trained at the University of Chicago and then was down at the University of Florida a long time. But the value of radiation, he said, was extending the margin, and that's the way we think of it. Again, like the radiation therapists, we are local. Surgeons can't really affect you systemically. They can just affect a local scene there. The traditional treatment in Dr. Enneking's day, and in fact, my mentor's day up to 25 years ago, was amputation. Everyone had an amputation. If you had a thigh sarcoma, you had a hip disarticulation. The reason for that was we didn't have MRI, we didn't have imaging. We couldn't tell where tumors started or stopped. And to do anything more local than that, high risk it would recur and high risk it would end up in death. So the most common operation my mentor, Dr. Mike Simon, did was a hip disarticulation throughout his career. He rarely rebuilt anything. It was only later that we sort of got into these other things. And at that time, there were no effective adjuvant therapies. Radiation was not where it is now, and certainly chemotherapy was not where it is now. Oops, sorry. So this is that same photo just with a leg in it, and this would be for a soft tissue sarcoma. And you can see if the sarcoma is located in the quadriceps muscle, which is the anterior compartment of the leg, so if you imagine that allows you to kick, straighten your leg out correctly. If you do a marginal excision, it's highly likely to come back. But if you do a wide resection, you're okay. It's probably not going to grow back. Radiation will help you keep it. Now, what happens if you remove somebody's quadriceps? Well, they can still walk, and I'll show for you. And the people with polio taught us this. I did 14 months of polio training. So you can walk without a quadriceps by swinging your leg forward, planting the heel, and stepping over. You really don't need the quadriceps. And it works well in other spots too. The hamstrings you don't need. You don't need every muscle that God gave you, so that's a fortunate thing. But that's the type of operation that used to be done. The same holds true for bone sarcomas. So if you had a bone sarcoma rising in the distal femur here, in the old days you'd have a hip disarticulation because you want to remove the entire bone. You had no idea where that tumor started and stopped. Nowadays we just remove the end of the femur along with some muscle and replace it. Bone sarcoma has been an enormous success story compared, I think, to other cancers. 25, 30 years ago, osteosarcoma had a 20% survival rate. And now that survival rate is about 70%. Another sarcoma we treat, Ewing sarcoma, was uniformly fatal. And now it has over 70% survival rate. That has nothing to do with surgery, I'm a little ashamed to say, but it has to do with my brethren here, the more cognitive brethren who give chemotherapy and saving lives. So this all had to do with chemotherapy. And the people that were responsible were Dr. Farber, you might have heard some of these names, Sidney Farber, who was in Boston at the time, Dr. Jaffe, who was down at MD Anderson, I think he's just retired, and Dr. Rosen, who was in New York, LA, and then back in New York. But in those days, Dr. Jaffe had a population of children with Ewing sarcoma, and they were, with osteosarcoma, I'm sorry, and they were dying. He had nothing to offer them. And he went to Dr. Farber and he asked him, can I try this drug called methotrexate? I'd like to give it a shot. And you know, some of those kids actually did pretty well. They responded to the drugs and they were eventually saved. Now, it wasn't easy for Dr. Jaffe. He had to face off against the Mayo Clinic, who said he was wrong, said he was poisoning children. But the facts are he ended up being right. And it's really one of the most tremendous success stories, I would say, certainly in my field, but I think in oncology in general, that chemotherapy for osteosarcoma has proven to cure more kids now than ever. And most kids that I meet now that have an osteosarcoma, as devastating as that is, will be cured of the disease. Couldn't say that 20 years ago. Multi-agent chemotherapy improves survival. We could give it before surgery, so we could make some plans to build the limb that we could put in. We could measure how much tumor was killed by the chemotherapy, so we could alter that a little bit. And we could, again, plan the operation. In the old days, we'd have to draw out a map and send it to the company, and they would make us a prosthesis and send it back. We always hoped it was the right side, okay, because you never want to put a right knee in a left side or anything like that. But you were always dealing with companies on that way. And it was done very well. Children in particular did well with chemotherapy. We had parallel developments in limb salvage, and I believe the Cubs may have won, is the rumor out there. I'm not sure. Okay, Tom, they won? Okay, good. So they're winners. Okay. Nobody head north. Everybody stay in the room just for the next hour or so. Okay. But this man on the left is Bill Inneking. Again, he and Mike Simon. Mike Simon's down at the University of Chicago. Those are my sort of academic parents. Big into developing the early forms of limb salvage, and it was not pretty, I would say, for the first 10 to 15 years. The man on the right is a man named Henry Mencken, who was at Mass General, who still goes to the office every day. Right now, what we use are cadaver grafts called allografts. So people donate their bones the same way they donate their eyes, their hearts, their lungs. Bones, we take all of the long bones, if people are willing to donate those, and we keep them in bone banks just the same as other tissues. Unlike other tissues, you don't reject them. We don't have to give you cyclosporin or anything like that to keep your immune system down. But this person, you can see, let me see if I can show you here. That's coming up, good. So the tumor was here originally, And what we do as carpenters is cut that bone and fashion a cadaver graft and fit that in its place, and then put plates, screws, rods, whatever the orthopedist likes to use to get that back together. And so for any tumor between joints, that's what we do now. We use cadaveric allografts to work with that. So we appreciate people who donate their body parts. It helps us do our work. For anything that involves a joint, I'm sorry if this picture's at all gruesome. I tried to take out most of the gruesome ones. We can replace virtually any long bone in the body now. We can do the femur. You can't really do the tibia well, but you can do the humerus femur with a hip and a knee, and it works quite well. There was a lot of discussion early on about what was best, but I think we've all decided now that allografts have a role, as do prostheses. Now, the original prostheses didn't work very well. So a lot of people had these implanted, and we learned a lot from those mistakes, I would say. Some of the original knees look really nothing like knees. I don't know what that really is, but somebody thought that was a good idea to put into somebody. There's a lot more rules now about what you can put into somebody, but you really can't put a fixed hinge into a knee. The knee's not a hinge. Doesn't work particularly well. And then these little stubby things, they just didn't hold up all that well over time. So what's gone on the last 25 years, a good collaboration with industry. Now we have these systems. They bring in a box, and we can put together virtually anything on the table. No custom components any longer. We can do hip all the way down to the lower leg if we need to do that. And all the pieces hold up pretty well, so that the overall survival now is about 70% at 10 years of the limb without having to be redone in some way. So pretty good results with that, certainly compared to the old days. So consensus now is we now do limb salvage for almost everybody we can. We use metal endoprostheses around joints, allografts for intercalary resections of that area in between. They both have a relatively high rate of complications. So it's not your grandmother's total knee or your grandmother's total hip. There's still some problems with these joints, but they actually do quite well. Considering you're putting them in teenagers, 20-year-old, 30-year-old, they actually do very well. So if we see a young person with this X-ray, and if I can show you here, this is the cancer here eroding out of the bone, and that's an osteosarcoma. And that's what it looks like after you take it out. We will now routinely put in a cemented hinge knee or rotating hinge knee, and that patient or child will do quite well, usually throughout their school years into middle life. And then sometimes we're going to have to tweak it a little bit, fix it later. This young person here had an osteosarcoma in between, and as I shared with you before, what we do there is put in an allograft, a cadaver bone. And my biggest problem with him was 4 years later, him wanting to go back to play football, which we can't really allow that to happen. Although I have 4 kids, they don't listen to me either. I'm not sure why. I think my other kids listen. Limb salvage is a wonderful thing. I would say it's better to have a sensate foot. If you imagine walking without sensation at the bottom of your foot, it's very hard on uneven surfaces. It's hard to get around. Cosmetically, particularly in the high school or young 20s age, it's better to have a leg, I think, than not have a leg. I got to tell you, though, there's no psychosocial effect for amputation versus limb salvage. There's less disability. You can get around a little bit easier, but actually, I don't allow people to do anything but walk, swim, or ride a bike. So if someone wants to play football or wrestle, I'm going to do one of these other operations. I'm not going to put a prosthesis in those people, even in their 30s, 40s, 50s. They won't tolerate that sort of activity. We do a lot of reoperations, and fortunately, whatever you do, you don't compromise survival. So that's the good news. Functional assessment, no study shows that limb salvage is actually better. It's hard to measure function. Function's in the eye of the beholder in a way, but both have distinct abilities and disabilities. So it's hard to get around. It takes more energy to get around with an amputation, but you can snow ski, you can do anything you want. If you break the leg, you need to buy a new leg and have that fit for yourself. It's one of those things. When you measure physical function or mental function, they're all the same. And it's interesting that people with amputations actually have a little bit higher mental function if you measure that. And I think that's that overachiever attitude you saw again in the polio population, or people who have chronic diseases tend to be overachievers. They tend to really push ahead, and that pertains to a lot of people in this audience. The function is all related to what muscle has to be removed, what nerve has to be removed, if any, and what bone needs to be taken out. And we can take out a lot, but there's a certain point where you take out too much, and people can't get around. And what we want really is for a hand to be able to placed in space. We're not really going to throw a fastball. My goal is for you to be able to put your hand in space. Get your hand to your mouth, feed yourself, do your hygiene, do some computer work, things like that. If we can keep the hand function at that, we've done our job. Lower extremity is all about walking. Kicking a football or running. Dr. Golnick's a big runner. I run only when chased. So it's all about walking, okay? And if walking's your goal, that's a good thing. All right. So nowadays, this proximal tibia section, what you don't see here is that we have moved the muscle in the back of the leg to the front of the leg in order that this patient can now straighten the leg out. Okay, because there's no way to straighten out your leg with a metal prosthesis. You can't do it. Nothing's hooking in there. So we will move the muscles around the leg to allow people to straighten it out, and it works quite well. This is a gentleman who was treated for rotator cuff problem for a long time. Sarcomas are rare. We've talked about that a little bit. Rotator cuff problems are common. Finally, we got an x-ray that went a little bit further down the arm, but we can replace the humors. It isn't perfect, but it works. It allows him to put his hand to his face and get the work done that he needs. Pediatric population. So we've gotten into probably most of my interest now is pushing towards a pediatric population because we're trying to spare their joints. We have some growing prostheses. I'll show you some of them, but they're not perfect. And if we can spare adult or children's joints, in other words, the joint surface, we'll be better off than if we replace all those joints in the long term. So we use, again, those intercalary allografts and a lot of metal, heavy metal. They call it orthopedic nirvana when you get in there. So this is a sarcoma with a fracture. That's a growth plate for those of you. It's a young child. In the old days, we would do an amputation for this, okay? The second choice would be to resect this, go back one, resect all this upper portion of the tumor and put a metal prosthesis in. But this is when we were just starting. I decided we could carve around this tumor and put a cadaver graft in, put plates there, and then as she's growing, take these screws out in about a year or so, the ones that cross the growth plate, and allow her to grow off, so that she'll resume her growth once you unlock things. And you can see her here growing off of that plate and maturing. And this is her in her 20s with a pretty good leg and no more operation. So that worked well. We're getting a little bit closer now to tumors. We may be getting too close, but it often is with these sorts of x-rays, as I said, orthopedic nirvana, clips, staples, metal screws, all sorts of things. I can tell you, if the bone doesn't heal, the plate's going to break. So you've got to get the bone to heal. And he did quite well until he was in his mid-20s and fell down the stairs. So we fix that. We fix that later. Okay, so this is just an example of that. So this is a sarcoma of the proximal tibia. As you can see, they don't respect the bone. They grow out of the bone and grow into the muscle, grow out into the muscle here. But we can cut around in this sort of using x-ray in the operating room. Now, a big new thing is for us to do computer guidance. So if we can get that worked out, we're probably about 3 years away. We can actually link it in the computer and put it in the room and actually have our tools linked to the computer so we can accurately make these cuts, confidently make these cuts. Right now, we do them freehand like an old-time carpenter. There's no great expandable prostheses. You can imagine children need to grow. This is an operation called a Rotationplasti, which I do for people who want to play sports. If they want to play football, it looks horrible, I know, it's sort of shocking, but it actually is the most functional operation for a distal femur problem. What you end up doing is taking the entire limb and spinning it 180 degrees so that the ankle becomes the knee, okay? And they put a prosthesis on that foot and they function extremely well. These are the people you see dunking the basketball and doing quite well. Because that sort of functional below knee amputation is what it's called, is probably the best operation actually for small children. It's just hard to talk parents into it. It's a very common operation in Europe, but less so I'd say in the United States. But that's a Rotationplasti, a very functional operation. We still do growing prostheses. We have another one tomorrow. This is a French design. I won't badmouth the French, but it's a little different, okay? So it has a spring inside, and then there's some gelatinous material that gets hard, except when it's microwaved, okay? So you'll put this in the child, and then you'll bring the child back. microwave the leg, and the spring expands. And then the leg gets longer. And then you stop, and it refreezes. It's a terrific idea. It actually does expand, but the prosthesis is not a good one. It's plastic, and it tends to fracture and then have these catastrophic sort of failures where things fall apart. So we don't use this too often anymore, but it's a great concept. This is an example of a child doing it. You have the child do it because they can know how much pain they're in as they're lengthening their own leg, and they stop. You don't want to be the one on the button because you'll go too far. But that's the microwavable component there, making the leg longer. Is the x-ray that you watch. You can see this distance here, but the spring here to here, and then once you microwave it, it expands out. So the leg grows about 1.5 centimeters, 2 centimeters. You can't go too far because you'll stretch the nerves and the vessels. That's never very well tolerated. Future directions, cementless fixation. We have a lot of problems with cement, bone cement. Metallurgy, we still have issues around cobalt, titanium. You hear about them in the news. We still have no way to get tendons to grow into metal. That's a problem. We are currently starting to look into coating all our prostheses with silver to try to prevent infections. Silver is pretty cheap right now, so it works out pretty well. Osteolysis, this is the problem with prostheses. They get loose over time. Some new strategies to fix that. This is called the compress, which I don't know if there's any mechanics in the audience. Very simple. Buy concave washers, 6 of them loaded up here with a literal nut here, okay? And we pin it to the leg, and then we load those washers to 600 pounds of pressure. And what the body thinks is that it's seeing weight all the time. And when bones see weight all the time, they get very thick and very tough. And it actually results in the bone growing into that prosthesis. So long-term fixation. So this is exciting technology called compress. Not perfect, but pretty good. This is an example of a patient I got up from Miami, and this was the initial. And you can see over time how that prosthesis, this actually has little pores on it that the bone grows around. And that's a total hip arthroplasty. All right. Amputees, we're trying the same thing. We just have an FDA out this year, I believe, and a visiting person from Europe. The fact is, most patients with amputations, most of the problems have to do with the soft tissue envelope around the prosthesis and problems with skin and wear, and really, that's the biggest issue. In Europe, they've had some success implanting, just like you do a dental implant into the end of the bone. It sticks out, and then before you leave for work in the morning, you snap your leg on. Go to bed at night, you unsnap your leg. And it's skeletal fixation. It doesn't count on the skin doing anything, because the skin doesn't like to be rubbed all the time. It gets blisters and other problems. So my partners in RIC and I are looking at this and trying to work with the team with the University of California, San Francisco on osseointegration. There's some other exciting things in amputees. The war brings a lot of bad things. It brings some good things. One is the C leg, which is a very good microprocessor to try to manage your gait if you do have an amputation. It's expensive. If it gets sand in it, it doesn't work very well. It's hard. Some patients can't get them, but there are advantages with these sort of computerized ways to manage how the leg swings and how you walk. The biggest thing here at Rehab Institute Chicago is targeted nerve reinnervation. So for upper extremity amputations, it's a real problem for patients, because to lose a hand, the brain is so dominant in the use of that hand that to not have it is a huge display, far higher than anything in the lower extremities. So what Dr. Damanian has done is he'll take the nerves from the amputation and implant them into the muscles of the chest. And those nerves, as they fire, if somebody wants to bring their thumb to their index finger, you'll get a characteristic electronic signal in that muscle. And then what Todd Kuiken does at RIC is put a chest plate on with hundreds of little sensors. And if the patient's telling themselves to pinch, they picked up the pattern that'll make the prosthetic hand pinch. Now, you still can't have sensation, but the motor function is tremendously good. They're a little heavy. You have to be young at this point to actually hold them, but I'm sure with time that'll get better. And you can imagine people with bilateral amputations benefit a great deal from these devices' ability to use their hands. So I think that's it. I thank you very much for your time and attention. We've come a long way, and I appreciate, again, you being here.